Hello, good afternoon, everyone. We hope you're doing well today on this lovely Friday. Welcome to our webinar, or Learn at Lunch webinar today on obesity, diabetes, and other uses for GLP-1 agonists. My name is Allison Elsner, and I'm CEO at the San Bernardino County Medical Society, and I'm joined by my colleagues, Janice and Debbie and Soteria. We're very excited to bring you this educational session today. We do want to thank our very generous sponsor, ProAssurance Medical Malpractice Company, and they have been a wonderful friend and supporter to the medical society, as well as all of our physicians and many of you out there. So we do thank them for being a partner in helping to open up the educational horizons for many of our providers. So, all right, we're going to get to it here. I'm going to introduce our esteemed speaker, and we want to encourage you to go ahead and enter any of the questions you may have into the chat feature as we go along. And what we'll probably do, unless the doctor would like to take questions as he goes, we'll probably wait till he's finished, and then we can go through the questions and look into the chat, as well as have any of you raise your hands if you would like. So with that, we are so excited to welcome Ricardo Correa, MD, educational doctor, F.A.C.E, F.A.C.P, F.A.C.M.Q, and a very good friend of the medical society and the medical community. Dr. Correa has been involved in so many projects that the medical society and all of us nationally have been involved in for the past few years. So we are very happy to follow him. Dr. Correa is the Program Director for Endocrinology, Diabetes, and Metabolism Fellowship and the Director for Health Equity Center at the Cleveland Clinic in Ohio, Clinical Professor of Medicine, Director for Longitudinal Didactics, and Director for DEI on Mentoring of Cleveland Clinic Lerner College of Medicine of Case Western Reserve University. In addition, Dr. Correa is the Health Equity Fellowship Director for Creighton School of Medicine in Phoenix. His work centers on decreasing diabetes and obesity disparities, especially among Hispanic populations, using peer support programs. However, he's recognized as a national expert in the advancement of these chronic conditions and understanding the patient perspective, including assisting with pharmacological intervention. His accolades go on, and I do encourage you to, I'm sure if you're online and search for him, you'll find much information, but we are really honored to have you here, Dr. Correa, today. So I'm going to turn it over to you, and thank you.
Yeah, thank you so much for the invitation. Thank you, everybody. Really appreciate it. I think that talking about this topic is so important nowadays because many of our patients are trying to learn a little bit about this. So I want to focus today in the GLP-1 world, but I will not talk so much on all the evidence that there has been found in diabetes. It's very well known and all of this. So it is a different topic. So this is more other things besides diabetes that have that you can use GLP-1s, and you will see from the most important one that is the ones that will have more evidence in obesity, but also cardiovascular disease, muscle mass, PCOS, and ending in some ones that are low evidence, but it's something promising for the future in neurodegenerative disease like Alzheimer's and Parkinson, in cancer, and in depression and substance abuse. So you will see all of this new molecule GLP-1 agonist, how there's some evidence that interact with some of the things from our brain, our gut, and other part of the body. So let's start. I really don't have any conflicts. The only thing is that we're developing a curriculum with 9 other medical schools on obesity, and the sponsor of that curriculum is Novo Nordisk. So really, the medication GLP-1 agonist was approved first for diabetes. And in all the research that they were doing, they found different mechanism of action of what a GLP-1 is. So basically, you can see that in the brain, the GLP-1 decrease appetite, increases satiety, decrease food intake, and has some neuroprotection in the brain. And we'll see that more when we talk about neurodegenerative disease. In the kidneys is natriuresis, so promote sodium excretion. In the heart has some endothelial prevention, endothelial dysfunction prevention, has some increase of blood flow to the heart. In the liver, we see that there is decrease in gluconeogenesis and increases glucose storage, glycogen, and then decrease in glucose in general. In the GI tract, it goes decreased mobility, gastric emptying, and gastric acid secretion. We know that in the pancreas, increased insulin secretion, decreased glucagon, increased survival of the beta cells. So one of the things that it was studying prior to being approved for diabetes was in patients that have transplant from beta cell transplant. The ones that have more improvement in survival of those beta cell transplant that were implanted in the liver was GLP-1 agonist. In the muscles, it's increased muscles and increased insulin sensitivity. And we know that increased lipolysis, so decreased lipids, improve lipid panel. So if we think about the first one that we are going to talk besides diabetes is obesity. So if we think about obesity, obesity is a chronic condition where the patient will develop different things. Insulin resistant, we know glucose intolerance, inflammation in the body. We know that this will go to the pancreas, cause some pancreas damage, beta cell damage, that at the end will also, besides the insulin resistant, it will be insulin decrease of insulin secretion. So if we look at the bottom, we can see that GLP-1s do different things as we were talking about. For example, decrease the appetite and decrease the gastric motility. And then this will, it will cause weight loss. And then this definitely increase insulin secretion and decrease glucagon. And this will cause decrease in the glucose in the body. So the ones that are in the market are this broad spectrum of GLP-1 agonist. The first one that came was the short-acting exenatide that was 2 times a day. The brand name was Viera. Then we have lixasanitide and then liraglutide. Those were the short-acting GLP-1s, meaning that it's once or twice a day. The long-acting GLP-1s start with Bydureon or exenatide long-acting, different from the other one. And all of the next ones are once a week. So then you have dulaglutide, albiglutide that is not anymore in the US, and then semaglutide that is probably the most famous of this group. So if we are talking about the benefit, before we start talking about the benefit, I think that it's important to focus on what are the side effects that this medication has. And really, it is very, with a lot of studies and systematic reviews that shows that really the most important side effects of this medication was the GI tract side effects. So some nausea, vomiting, diarrhea, constipation. But the good thing about it is that really when a patient comes to you to ask you about GLP-1s, there are potentially ways of decreasing the complication of the side effects. For example, if you tell the patient to reduce the meal size, or that stop eating when they're full and decrease the eating of high fat or spicy food, that will help to prevent those nausea, vomiting, those GI tract disruptions that happen with the GLP-1. Another way is to start slowly titrating. I know that sometimes patient wants to start with the maximum dose. Let's see if this is Ozempic 1 milligram, but it's always good to start with 0.25, at least give the patient 2 weeks or 2 injections, and then start increasing the dose to see less side effects. What are other side effects? That has not been a lot of evidence, but there has been some kind of evidence. First of all, there is a risk of medullary thyroid cancer. This is more a risk that has happened in rats, not in humans. And really, we know that the proportion of C cells that those rats has is higher than humans. and then the dose is different. So really we have never demonstrated that increase the risk of medullary thyroid cancer in humans, but because the risk is in rats, then we are concerned about that. So that's why in people that have medullary thyroid cancer or family history of medullary thyroid cancer or multiple endocrine neoplasia type 2 is not indicated, it's contraindicated for those group. The other thing that we talk a lot about is pancreatitis. Yes, really the clinical trial has never established a cause of GLP-1 causing pancreatitis, but because there is that kind of risk, we try not to use it in patients with chronic pancreatitis, not with acute pancreatitis that you knew that was or alcohol or a stone. Then you can continue with the medication. So there was one report last year about a patient that died for ileus when it was on GLP-1 agonist. It's one case. It's not been really a side effect, but you have to, because the increased motility of the GI tract, be concerned if the patient is having some of these issues that probably ileus can appear. And then really if the patient has some gallbladder disease, it's better to solve that prior to starting the medication. So what are the other actions besides the glucose metabolism? So we know that in the brain, increased synaptic transmission, increased memory, neuroprotection, and increase the signal of satiety. In the lipids, increase lipolysis, meaning that there's more free fatty acid and more glucose uptake by the fatty cells. In the liver, decrease hepatic steatosis. In the myocardial infarction, decrease blood lipids. Endothelial dysfunction decrease. Decrease the gut emptying, as we were talking, and then the kidneys increase natriuresis. So let's first start with the first indication of GLP-1 agonist, obesity. So we know that it promotes weight loss by the mechanism that we thought central and peripheral, in the GI and in the brain. It was FDA approved. The first GLP-1 FDA approved was liraglutide for weight loss. And we know that the mechanism of action is dual. So it have central and in the GI tract. So let's see how this was progressing in time. So we know that the first GLP-1 came to the market in 2005, and this was the exenatide twice a day. And the approval was for diabetes. If we look and we move to 2014, that is when the first 4 years after liraglutide was approved for diabetes, was really approved for obesity with a higher dose. Then after that, we have a jump of almost 6 years, where really there were a lot of other GLP-1s approved for diabetes, but really were not for obesity until in 21, sorry, 6 years until 21, semaglutide was approved in the name of Wegovy for weight loss. And then really last one that was approved was a combination of the GLP-1 and GIP, tirzepatide as the name Zepbound in 2023. So really the other thing that we have is that really in 2020 was when liraglutide was approved for kids and adolescents. So children and adolescents in 2020. So as we can see, really at that time, the progression in diabetes was so much compared with the progression in obesity. Nowadays, we see a little bit of shift. There's medication are being more and studied in obesity than in diabetes. So these are the different types of GLP-1 agonists. So if we see, as I mentioned, the exenatide twice a day, the liraglutide once a day, then they would start the ones that start every week, the long-acting ones. And then all of them are oral or subcutaneous. There is one that is the semaglutide oral called Rybelsus. That is the one that is oral. That one is only approved for diabetes. It's not approved for obesity. There are some studies, and I will mention this, that are looking at oral semaglutide for weight loss. When we compare the different actions regarding the weight and decrease in weight, we see definitely that semaglutide is the one that have more weight loss. All of them have some weight loss properties. So if you think about liraglutide, that was the first one approved, it's approximately 3 to 5 kilograms of the weight. So that's very relevant. But definitely the long-acting and semaglutide being the most important is the one that have demonstrated more weight loss than the rest. So let's start with the studies of semaglutide because it's so, this is the drug that is so famous. So the first one, here you are, the first one was step one. Step one is a randomized controlled trial comparing placebo with semaglutide in patients that didn't have diabetes. So these patients are with patients that have obesity. And you can see here definitely at the end that there is approximately a 14 to 16% difference in weight loss between the placebo and semaglutide. Step two was patients with diabetes randomized to 3 groups. The placebo, the semaglutide 1 milligram, this maximum dose of Ozempic, and semaglutide 2.4 milligrams, the maximum of Wegovy. And you can see that the higher the dose, the more weight loss was beneficial for the patient. And these are all the trials that have been studied semaglutide. So step one, as I mentioned, was patients without diabetes. Step two, patients with diabetes. Step three was patients on top of the medication have behavioral changes. Step four is what happened after we discontinue, if we continue the medication after the trial. So this was a follow-up study. Step five was patients without diabetes treated over a 2-year period. Step 6 and 7 was more in other population. And step 8 was comparing semaglutide with liraglutide. Then all the studies that use semaglutide as cardiovascular protection are called SUSTAIN studies. And you can see SUSTAIN 1 or 2. And then the studies are now evaluating the oral semaglutide, is OASIS studies. And then they are evaluating a higher dose of oral semaglutide for weight loss. Step one, as I mentioned in the two prior slides, really demonstrated approximately between 14 and 16% body weight reduction from baseline after the 68 weeks. And if we look at here, we can see that 92% of the patients lost more than 5% of the weight, 75% of the patients lost by 10% of the weight, 55% of the patients lost more than 15% of the weight, and 35% lost more than 20% of the weight. So impressive. Before this drug, all of the studies only demonstrated more than 20% of the weight in 1 to 5% of the population. This jump to 35%. So this was what just bumped the medication to the approval for obesity. What happened with diabetes? As we compare the same thing trend, patients, the step one was without diabetes. In diabetes, the maximum dose was more beneficial for patients with diabetes for weight loss. What happened with if we add behavioral changes? So this is the study where they compare placebo semaglutide with behavioral changes. We see again same pattern, weight loss, more weight loss than without behavioral changes. What happened when if we continue the medication or we stop it? So if we continue the medication, they continue the pattern of weight loss. But if we decrease the medication or we switch to placebo or stop the medication, you regain the weight. So this demonstrated that really the use of these medications is more chronic than acute. And this is how we should be thinking about obesity management. It shouldn't take a long time. There, when the study was 68 weeks, but there was a prolonged study until 104 weeks. And yes, continue. The same weight loss was continued there. And finally, the one that compares liraglutide with semaglutide. So they compare in 3 arms, placebo versus 2.4 of semaglutide versus liraglutide 3 milligrams. So these are the maximum dose of each one for weight loss. The trial was 68 weeks, and it was including patients that had obesity or more than 27 of BMI with some complication related to not diabetes complications. And you can see here that definitely both drugs at the beginning start performing very similar. And you can see that then at the end, semaglutide produced more weight loss than liraglutide. So this is what we found in the use of, and that's when they switch from being on a GLP-1 agonist like liraglutide switch to be more semaglutide type. So just back again, because I want to talk about the other medication that is a combination therapy. The GLP-1s are secreted by the L cells. We know the effects, as I mentioned, the GIP is secreted by the K cells in the duodenum. And these are also an incretin that's also slow gastric emptying and cause some anorexigenic compared with in conjunction with GLP-1. So these are the two molecules. The ones that I want to mention here, we are been talking about semaglutide, but tirzepatide is the other molecule. And this is a GIP that can interact with the GLP-1 receptor and the GIP receptor. And is also an injection once a week with the modification that they did. So before we start looking at the trials that demonstrate that tirzepatide is even decrease more the weight, it's important to mention that if a patient comes with diabetes and you want to manage the weight too, the recommendation from the American Diabetes Association is to go to the high or very high glucose lowering that have beneficial on weight. And these are the semaglutide or tirzepatide that's very high, or liraglutide or dulaglutide that's high. So let's start with the studies of tirzepatide. So this was a randomized placebo trial in 3 doses of tirzepatide, 5, 10, and 15 milligrams, 72 weeks of follow-up in patients that were the same criteria for the step 8. Patients that were more, they were more than 30 or more than 27 of BMI, but have some complications. What they found, impressive results. The maximum dose of tirzepatide reduced approximately 20 to 25% the body change percentage from beginning to end, comparing to placebo. All the others reduced like 15%, the 5 milligram, very comparable to what semaglutide maximum dose were doing. 10 was 19 to 20%, and then really 15 was the one that achieved 20 to 25%. If we think about it, approximately what we do during bariatric surgery is 30% weight reduction. So this medication are really approaching to bariatric surgery, what the bariatric surgery does. What were the primary endpoints? Basically was percentage in weight change from baseline to 72 weeks. And then the reduction more than 5% at the 72 weeks. And then definitely it was demonstrated in both of them. So this SURMOUNT-2 is the tirzepatide study, and is compared here with the step 2 that was the semaglutide study, both in patients with diabetes. So you can see that the weight reduction definitely is higher when we see tirzepatide higher doses. So the semaglutide go to 10.6% difference. Then when we start tirzepatide 10 is 13.4, and then tirzepatide 15 is 15.7. So it's comparing the both studies, the step 2 and SURPASS-1 and 2 is just placebo versus semaglutide, or placebo versus tirzepatide, or semaglutide versus tirzepatide. And these are the baseline characteristic of the patients. But what I want to show you is that the reduction in body weight definitely is very impressive even when you compare semaglutide and tirzepatide. Adverse events of the tirzepatide very similar to the ones of the GLP-1 agonist, is mainly GI discomfort, and using the same techniques of small meals, stop eating when you're full, do not eat spicy food or fat food during this time. That helps also to decrease the GI side effects. So in summary, there is certain progression of medications in the body weight loss world. Starting with the first one that you can see, Orlistat, lorcaserin is not anymore in the market, sorry. The phentermine, topiramate, and naltrexone, bupropion. But then when you jump to GLP-1, you see a bigger reduction on weight, definitely when you get into semaglutide and then the dual action with tirzepatide. But there is a lot of things that is coming. So we have certain medications, for example, a triple agonist, then glucagon, and this preliminary data from those studies are they are getting close to 30% weight loss. We have amylin and GLP-1s. We have other medications that promote muscle growth. So there is so many things that is happening in the horizon for targeting different things for obesity. So this is something that probably in 2 or 3 years, we'll be talking totally different as how we were talking about 5 years ago. So all of these studies are in process with multiple combinations of things. The one that probably will be sooner is the one that is glucagon, GIP, and GLP-1. Okay, so let's talk about metabolic fatty liver disease. So in the past called NAFL, now MASL. In 2018 was the first time that GLP-1 showed to change histology in patients with MASL. In 2020 was the first time that GLP-1 was approved for FDA approved for muscle MASH, and that was semaglutide. In 2021, dulaglutide was approved for the same indication. So we know that there's a combination of things, and this is just fatty liver. Then definitely controlling glucose is important, and then now we have on top we added GLP-1s. So what GLP-1s does is, one is that reverse the action of fibrosis, improve liver histology, reduce liver enzymes elevation, has some anti-inflammatory effects around the fibrotic areas. We know this from diabetes, improve insulin sensitivity, and then we know this from obesity, they improve weight loss. So all of this to benefit the reversal of that fibrosis that were happening. Let's talk about polycystic ovarian syndrome. So we know that GLP-1 also has, and patient with PCOS, remember when I trained, always the recommendation was, okay, OCPs and then metformin, besides lifestyle modification. I think that in all of this, we have to always go back to the basic. We have to do lifestyle modification first and then medication. But PCOS nowadays is very managed by GLP-1 agonist. They regulate menstrual cycles, reduce the risk of miscarriage. So women with PCOS, we know that have an increased risk of miscarriage because of the utero lining, and this GLP-1s improve utero lining and improve ovulation too. So these are things that patients with PCOS will benefit if they are on GLP-1s. What about cardiovascular risk and cardiovascular outcomes? Well, with all the discernment studies have shown that really there is benefit in MACE and in myocardial infarction, stroke, and cardiovascular mortality. We're going to see some of them. Why this happened in cardiovascular? At the beginning, they thought that this was a consequence of the benefit in weight loss and diabetes control. But really, besides that, when they adjusted, there are other things that are helping also to produce this cardiovascular benefit. And when you look at the physiology of GLP-1, you can see that it's expressed in the left atrium. There is receptors expressed in the left atrium, direct the action of cardiomyocytes, have anti-inflammatory properties, have an action on the endothelial cells, the action on renin and angiotensin-aldosterone. So we know for some other studies that decreased aldosterone in patients have a natriuretic effect, action on the natriuretic peptide, stabilization of the atherosclerotic plaque, and reduction in systolic and diastolic blood pressure. So as we can see, these are all the other conditions besides this metabolism with glucose and lipids that GLP-1s help independent of the other two. So studies showing benefit from GLP-1 on MACE, you can see this is this systematic review with meta-analysis that shows that all the GLP-1s, the GLP-1s, when you put it in conjunction, all the studies show MACE reduction, stroke and cardiovascular mortality and all-cause mortality. Myocardial function, they show a reduction. When we go independent of each of the studies on cardiovascular events, we can see that two GLP-1s are not indicated for cardiovascular protection. And this is lixasenatide with the ELIXA study. You can see that it crossed. And the second one is the exenatide with the EXCEL study. That's the one that also is non-significant. And oral semaglutide, not the one that is in study right now, but the one that was approved for diabetes that is also crossing one. And this is just, again, the same thing we were showing there. MACE here is all the other ones. And we see the same thing that for lixasenatide and exenatide, there's no cardiovascular or MACE or stroke or MI benefit. What about kidney disease? So the most recent study where they compare semaglutide and placebo shows that there is improvement in the macroalbuminuria. The worsening kidney disease decrease with semaglutide. And then the other ones were not significant, but double serum creatinine and renal replacement therapy were not significant. So we can see definitely that there is an improvement in chronic new or worsening of chronic kidney disease in patients that suffer that approximately of 36%. Okay, let's jump a little bit to neurodegenerative disease. So we know that here, including Parkinson and Alzheimer, there are some studies that have shown, some of them, that GLP-1 may protect the dopamine neurons and improve motor symptoms in Parkinson, basically in animal models. All of these studies that we'll talk from now on are basically based on animal models or very small group of humans. The Alzheimer, we know that GLP-1 reduce amyloid plaque and they improve cognition of models that have Alzheimer in animals. So for various reasons, there's increased insulin sensitivity. And if you think about the brain barrier is worse when you have insulin resistant. So it will increase the glucose in the brain, and this can cause some damage. So having some insulin sensitivity help, also anti-inflammatory properties, and it also improve neuronal plasticity. So there is more research to consider because really the data is coming mainly from animals and some small, as I mentioned, some small human studies. But this is something that is in the horizon for the GLP-1 agonist. So let's talk about Alzheimer. And then semaglutide enhance the autophagy and inhibition of apoptosis. Dulaglutide with the hyperphosphorylation of tau. Look, what happened is that there is an improvement in learning and memory. Liraglutide and exenatide found to be antagonist to neurodegeneration. And really the two drugs that has been more studied compared, we know a lot of semaglutide studies for obesity and muscle mass and cardiovascular protection, but really the drugs that have been studied in other areas, not the first ones, has been the liraglutide and exenatide. And in liraglutide, also in transgenic mice, prevent memory impairment and neuronal loss. So this is just a brief overview of what happened in a brain that has insulin resistant, you will see there is a neuronal dysfunction and degeneration and all of this. So this is what we call now diabetes type 3. So if we can improve this with GLP-1s, with increased neuroprotection, decrease oxidative stress, decrease the deposit of amyloid, decrease neuronal apoptosis, decrease cellular toxicity and synapses loss, then the patient will start getting better. What about Parkinson's disease? So we know, as I mentioned, GLP-1s have neuroprotective effects in animal models. So in Parkinson's disease mouse model, GLP-1 also reported to protect the brain from some pathological effects, such as the movement disorders, increase of alpha-synuclein, chronic inflammation in the brain, loss of the dopaminergic neurons. So we know that there is a direct effect of GLP-1s and dopamine. So patients that have exenatide use have an improved in 3.5 points in the exercise scales in places that have the Parkinson's disease. And really, the semaglutide also reverses the decrease in the level of thyroxine hydroxylase, alleviate inflammation and autophagy, the increase, so then the dopaminergic neurons are protected. What about depression too? So we know that GLP-1s improve neurotransmitter, decrease neurotransmitter imbalance and improve neurogenesis. So because of increasing serotonin, dopamine, GABA, and glutamate. So all of these are involved in the process of depression. Some studies have shown that the patient gets better. What about chemical dependence? This is another area. Basically, the study has been in patients that are using alcohol and patients that are using cannabinoids. There has not been studies in other type of chemical dependence, but what they found is that GLP-1s decrease dopamine release, decrease alcohol preference, and decrease withdrawal symptoms. There was a very famous study that came like, oh, GLP-1s decrease alcohol use disorder, alcohol use disorder. And then it was coming because of the effect of GLP-1 on decreasing the reward for patients that are in alcohol, and decrease also withdrawal symptoms. In general, the cognitive function of the study of what happened with GLP-1 and cognitive function, this is extrapolating the data from the Alzheimer's studies that that there is improvement in memory and in decrease in the impairment in patients with Alzheimer's. So the hypothesis is that will improve cognitive function in patients. Finally, let's talk about cancer. So really, this is the area with less evidence because it's just preclinical studies. There has nothing done in humans yet. We know that they inhibit tumor growth by regulating cell proliferation and apoptosis, and definitely we need more research. So when you think about different type of cancer, we know that many of those cancers are correlated with type 2 diabetes. In patients that have obesity and type 2 diabetes, when they were treated with GLP-1s, there was not increase of breast tumor or pancreatitis or pancreatic cancer or overall neoplasia. Definitely, also the study by Gear showed that there is not increase in new thyroid tumors. We were talking about the C cells, the medullary thyroid cancer. So there is no increase on that. Because of the inhibiting the mTOR pathway, there is decrease in prostate and pancreatic cancers. And then liraglutide and exenatide reported to have some apoptosis and autophagy, inhibiting the progression of endometrial cancer. So there is something to study. This is just physiology, but there is something to study. Remember, the molecule only lasts, the GLP-1 only lasts 3 to 5 seconds in our body. These molecules are lasting for longer half-life. What are the limitations of all these studies that has not been related with cardiovascular, nephrovascular, diabetes, and obesity? There are small samples. The study is short duration, and the data is very limited in humans. And with this, I want to thank you. This is a really 30,000 feet overview of the different mechanism of action or the future of GLP-1s, where they are going. At least we have a good evidence in the area of obesity, muscle mass, cardiovascular, vascular protection, and diabetes. The others are something that will probably benefit the future of the patients, but we need more studies for that.
Wow, that is just really eye-opening, Dr. Correa. Thank you so much. First, a couple of quick things. First, we want to wish you a happy birthday today. So thank you for letting us celebrate with you and celebrate you in general. This is a lovely way to have everybody in on this celebration together, getting to talk to you today. And secondly, I want to start with a question. Will you be willing to share your slides? Would that be
Yes.
okay?
Yes,
Okay.
yes, yeah. I will send it to Janice or.
Yeah, that'd be wonderful. Okay. So Ria, do you want to take us through our questions, maybe starting with Dr. Neeson's question?
Sure. Let me go ahead and scroll over to that. Okay. Dr. Neeson's question is, and the cardiovascular and kidney benefits are independent of weight loss, not of weight loss, not due to weight loss.
Correct. It's independent of weight loss. So definitely weight loss has a component in benefit there, but it was not strictly just because of the weight loss. That was the beginning thought of the GLP-1s have cardiovascular protection because of the weight loss and the glucose control. But really, when they dig more into it, they found that yes, there is an independent risk that is getting better with GLP-1s.
Wonderful. Let's see. The next question says, any pearl about getting insurance coverage for a patient on commercial and non-commercial insurance?
Yeah, this we were talking with Alice on this before we
Yes.
started. Yeah, this is extremely complicated because even we know so all the benefits that this drugs has, we still are fighting with the patients that do not have diabetes. That the recommendation is for obesity or even cardiovascular prevention to get this medication approved. So I was telling Alison that in the federal government, CMS is not yet approved this for obesity. And there was a bill, the TROAT bill about for approving for obesity that really we're trying to tell the budget people that if you take into account long-term, these medications use in acute setting, yes, it's more expensive, but long-term, you are going to prevent all the side effects of weight problems. But really, when one of the people, the policy people from Endocrine Society came to us, say, yes, but the budget of the government is 5 years only. So they cannot look more than that. So then they cannot see really the real picture because we are talking about 20, 25 years more, all the complications that that person will have. So that is why it has not been passed. There's still a lot of organizations are working together to pass this, some of the bills to help people, at least people at the federal government with Medicare that still not covered now, but nothing. And the state levels is different every state from state. So some get good coverage, others not. So a work in progress.
Wonderful. Allison, do you want me to ask your question next?
Why don't you skip mine, and then if we
Okay.
have time, we can come back to it. Would be great.
Perfect. The next question is, given the anti-inflammatory effects, is there a role for GLP-1s in chronic pain?
Yeah, so good question. There was a small study done in patients with osteoarthritis of the knee, and show improvement, but also it can be so improvement in pain, but also in this study, the patient lost weight. So we don't know if the pain improvement was because of the weight loss and then less stress on the knee, or was really to anti-inflammatory, or was both for both. But yes, there are some studies that are happening right now to determine that the decrease in pain, the GLP-1s are helping decrease in pain.
Okay. And the next, sorry, the next question, are there studies of GLP-1s who have obesity or metabolic syndrome and schizophrenia and or bipolar?
I don't think, I have not seen any specific trials with patients with obesity and schizophrenia or bipolar disorders. But it will be interesting to see. Remember, if we are talking about that they have some neuronal effects, the GLP-1s plus the weight loss, then it will be good to evaluate both.
What are the projections for long-term weight management and its impact on bariatric surgery?
Yes, so I think that what the obesity specialists are looking in this is that it's a long-term management. It's not something in acute terms, so it's long-term. So more studies need to be done to see what is the long-term side effects of this medication. We know that short terms are very minimal, but long-term side effects that we don't know yet. So that is going to happen. Really, regarding bariatric surgery, at this point, still many patients will benefit more with bariatric surgery than clinical management of obesity. I think that when we learn more about new drugs and other drugs, then probably we will shift a little bit between the surgery and medical management. At least what we have seen is that more people are opting now to do medical management than surgery if they don't have the criteria or the complications from that they don't want to have the complication of bariatric surgery. But I think that the horizon looks like probably bariatric surgery will start decreasing more, and then the medical management will start increasing more with the new drugs and all of that.
Okay. Can you address the risks of eye disease with the GLP-1s?
Yes. So basically, the issue with eye disease was in patients that have diabetes and elevated A1C, the rapid decrease of that A1C by using this medication increased the risk of eye problems. But this has been never demonstrated in a patient that do not have diabetes. So really the consideration is patients that have diabetes have high A1C like 12, and you decrease that in 3 months to 9, that decrease, dramatic decrease, can exacerbate some eye problems. In other situations, no. So you have to take it with a grain of salt, because really it was only in those cases. So definitely in those cases, we don't do GLP-1s. So we decrease the sugar first and then do GLP-1s. So the decrease is not so much. Patients with obesity has been never demonstrated to have this. Was a very controversial article published in Ophthalmology, Journal of Ophthalmology in England, that shows that this was, but really all of the conditions that the patient had in that study can exacerbate eye problems. So the patients were diabetes, were obesity, so all of that. So you cannot blame the drug. Really, at the end, it was a small study, I think 40 people. So it was not conclusive, not evidence. You cannot blame the drug for causing this.
When you stop the medication, do patients gain their weight back?
Yes, and you saw that in the step 3 trial, where they compare placebo, stopping the medication with continuous semaglutide, and then definitely the regain is there. Yes, it will happen. It's extremely difficult for a patient to not regain their weight unless during the time that they are doing the trial, they start changing a lot. It's extremely difficult. I have not seen a person. So what we recommend, because sometimes it's shortage of the medication, this is the problem too, that the production was not with the consumers, was not at the same level of the consumer. What sometimes I do is like prolong, instead of every week, I say every 2 weeks inject. So at least you that effect for another extra week. It really is long acting. It will not disappear from your body until 5 half-lives. So it will take more than 4 weeks to disappear. But at least you can start prolonging that effect if there is a shortage, and because immediately the patient go out of the medication, will start regaining the weight.
Mhm.
Now, what are your considerations when deciding between semaglutide and tirzepatide, assuming both are covered?
Oh, if both are covered, definitely I will go. And the patient is very interested in weight loss, I will go with tirzepatide. The thing is that usually we don't get, and then usually they have one or the other. But if the patient has been on semaglutide maximum dose and the patient wants to lose more weight, you can change into tirzepatide and the patient will continue losing weight.
And that's all that I have that I see.
Why don't okay, so my question, Dr. Correa, was, can you explain exactly why this is so effective with certain people and why other people don't seem to need it? I mean, a lot of us have known for a long time that some of our bodies metabolize things more energy more efficiently, but considering these other health benefits, that you're talking about, like potentially on Alzheimer's, Parkinson's, and all of the other cardiovascular benefits, does this mean that some people's bodies already regulate these functions more effectively, so the GLP-1s aren't really needed? So the GLP-1s are they come in kind of like an intervention in the body and regulate the hormonal response more efficiently, or does that make sense?
Yeah, so I think that, for example, if we think about many of these studies have been done thinking about the physiological patterns of the GLP-1. So we know that it's in neuronal, we know that it's in other areas in the heart. So why they have the receptors there, what is the benefit? I think that for majority of the patients, you will see a benefit in one area of the other when you give GLP-1s. There are some patients that do not respond. As anything in medicine, we're unclear why they will not respond to this kind of medications, but definitely it's not the common. The common is, if we think about obesity and diabetes, really in diabetes, I have not seen any patient that do not improve A1C with this medications. All of them, the A1C improve. But yes, but there are patients that will not respond. Unclear why. They have some probably GLP-1 receptor resistant that we are not aware. Like if we think about the same as insulin resistant, well, probably we have there's a GLP-1 receptor resistant. So that can happen in some patients, and then even higher doses, because this really the GLP-1 that we give to the patients is extremely high dose compared to what our body normally produce. So
Okay.
So that's something that also we have to take into account, that we are giving a high dose of the medication, and some people will not respond to that.
Okay, so what about like the inverse of that though? If you have someone who is at very low risk of developing type 2 diabetes and they've never had an issue controlling their weight and that sort of thing, does that mean that their bodies are already producing whatever they need to be receptive to these hormones? Or
if the patient have type 2 diabetes and has not required, there are some type, like we managed type 2 diabetes initially with not necessarily we have to jump to GLP-1s. Metformin is a drug that we use a lot and helps depending on the type of type 2 diabetes. I think that so in cases where you are looking for more in patients with diabetes for more other protections, for example, the patient have diabetes but have some kind of weight problem, and you want to also do cardiovascular protection, and GLP-1s will be the option. But in patients with type 2 diabetes that they are, for example, very low control A1C of 6.5, 6.7, the patient has benefit from metformin. We don't have to jump immediately to GLP-1. The benefit that we have is those patients with pre-diabetes and diabetes that have obesity, then they will benefit from these drugs, and it's approved. You get easily approval because you in your diagnosis, you don't put that it's for obesity. You put that it's for the treatment of diabetes. And even in pre-diabetes, it can escape. If you put pre-diabetes, sometimes it can escape and then they approve it for that. But really your intention is for the weight loss management. It's not for the other control because it's good control, the other one.
Okay, great. Thank you. And we have another question. Can you talk a bit about reversal of fibrosis? Fibrosis, by definition, is irreversible damage to the liver. How is it reversible?
Yeah, I think that a lot of the things that has happened in hepatocyte is the beneficial. There is fibrosis, but to prevent the continuation of the fibrosis, there is this anti-inflammatory effect of GLP-1s that helps. I understand that the fibrosis per se will be difficult to reverse, but then the progression of the fibrosis is what you control.
Great. And we did skip over an early question here that we want to go back to because you weren't focusing quite as much on actual diabetes discussion, but Ronald Clark asked, isn't type 1 diabetes more serious than type 2 diabetes, or is it the other way around? And at what point does a person go from type 2 to type 1?
Okay, so you hear me? Sorry.
Oh, yeah, now I can hear you.
Oh, perfect. Yeah, I think I got some lost signal. So there's two different diseases. Type 1 is an autoimmune condition when there is beta antibodies destroying the beta cells. Type 2 is a problem not of the beta cells per se, it's a problem of the insulin receptor in the cell where there is insulin resistant. So what happened is the first stage is that the body starts compensating for insulin resistance, increasing the insulin secretion. But there is a point that the body cannot secrete as much as it needs. And then it's when you have type 2 diabetes. Two different diseases. Most likely the type 1 is an autoimmune condition. It's caused by antibodies that destroy. Type 2 is a multifactorial. One of the main contributors of type 2 is obesity and the inflammation produced by the fat cells. So you are never going to progress from type 2 to type 1. What you can progress is from type 2 to insulin-dependent type 2. This means that it's a patient that initially you don't need insulin. The beta cells get tired, cannot secrete more and more and more. The obesity continue destroying, the inflammation continue destroying all those beta cells. And later on, the patient do not have production of insulin, and then you will have to go to insulin. But that doesn't mean that the patient changed to type 1. It means that the patient is type 2 on insulin dependent. What happened with, you cannot go from type 1 to type 2. What you can get is patient that have type 1, if they start gaining weight, they will have some insulin resistant. So now you have type 1 with insulin resistant. That is different than we having type 2. So I hope that I answered that question.
Great. Are there any other questions while we have Dr. Correa on the line? Would anyone like to raise their hand? I'm not seeing any raised hands. Well,
Allison, there is one more question in the chat.
Sorry. Oh, okay, great. Yeah, here it is. Does type 2 diabetes increase inflammation of our tissues? And can we use GLP-1 with a patient who is obese with an A1C around 6.4 with a family history of DM?
Of a family history of?
DM, diabetes.
Diabetes. Okay, diabetes. Okay. Definitely. So answer the last question. Yes, in a patient that have 6.4 A1C, that's the diagnosis of diabetes. So how using a GLP-1 if the patient have some obesity problems will benefit the patient definitely. And there's a justification. You say the patient have diabetes, so they will get approved more likely for the by the insurance. Regarding the first question about diabetes and inflammation, it's not really the diabetes. Really, the inflammation is caused more by the obesity and the fat cells causing this some interleukins and some of the things that will cause the inflammation in the body, not so much the diabetes per se.
Wonderful, thank you. And Ms. Pena, you have a question.
Yes, I do. So my question is, given the high prevalence or usage of these drugs, what direction or what recommendation do you make with primary care doctors in particular in preparing these patients for surgeries that are not bariatric surgery? I experience a lot of issues with getting patients adequately optimized for surgery because of the length of time before surgery. So what are those discussions or what are those learnings look like for doctors that are moving these patients through the GLP-1 continuum?
So that's a great question because we have a really two guidelines coming, and I don't know if you were focused exactly the preparative uses of these medications, but I can tell you that if the patient, when they start the medication and they don't have a lot of side effects, GI side effects, you should not stop for surgeries. Remember, this medication is have like long acting. So really, if you stop 2 weeks, because the tradition right now is to stop 2 weeks before.
Right.
So if you stop it 2 weeks before, and this is a long acting, still when you go to surgery, you will have the medication effect in your body. So really now the new guidelines that are coming soon, probably next year, address this, and they will say, if a patient have minimal side effects to this medication, you should not stop. The ones that you should stop probably 2 to 4 weeks before is the patient that have moderate and severe side effects of the medication. And then they recommend some of the kind of things like giving some amount of carbohydrate liquid, not depending 8 hours before, if you have mild symptoms, or you can be fasting for 8 hours. So it will depend, individualized on the patient, but I think that the new guidelines will enlighten us a little bit more on how to manage this, but at least it's not the standard right now to stop the GLP-1s before surgery. You can continue. The only thing that you need to monitor the patient and see, because if this is the topic as I mentioned, if you stop, then the medication will continue into effect. So you don't pass the 5 half-life for not having the medication on board.
Thank you.
Great. Thank you so much. Anyone else have a question? Am I missing any hands? No? Well, all right then. I'm not seeing anything else in the chat. And I just want to say again, thank you so much, Dr. Correa. That was just really, really awesome. We'd love to have you back maybe in a few months or next year when you're talking about some of these developments and studies have progressed. So maybe we can have you back to address some of this. And we do want to remind everyone, CME is available for this 1.25 credits, and Janice has shared up on the screen instructions for that. We will also email that out to all of you. I see there are a few physicians on the line with us, so if you'd like to receive CME for this, you can apply for that. And we will send out the slides and the recording. So with that, happy birthday, Dr. Correa, and thank you. That was really outstanding. We really appreciate it.
Thank you so much.
Thank you so much. And everyone else, thank you all for joining, and have a lovely Thanksgiving. And we'll talk to you all soon. Goodbye, everyone.